Welcome everyone to this session on pregnancy and endocrinology, and I hope you'll all enjoy this session. So my talk is on TSH targets in pregnancy. So the TSH targets in pregnancy, this topic has traveled a long way, and I think there is a better understanding today. And but however, contentious issues still remain, which will be the focus of my presentation. So what is known as the established link between thyroid dysfunction and pregnancy. So whether it is maternal health, fetal health, or neonatal health, there is an adverse outcome with thyroid dysfunction. So this paved the way for almost a universal screening for thyroid dysfunction in pregnancy. And the screening test of choice is the TSH. The TSH is most reflective of the cellular response to free T4, and hence it is a sensitive marker of thyroid status. So beyond ambiguity, what is very well known today is that we screen all women, and the screening test of choice beyond ambiguity is the TSH. But then the points to discuss are, what is a normal TSH in pregnancy? What are the TSH targets for diagnosing hypothyroidism? And when we treat, what are the targets? And a few slides on the relation between TSH and adverse pregnancy outcomes, and also TSH in relation to autoimmunity, pregnancy loss, and ERT. So these are the areas which I'm going to present today. Well, the first case is a 22-year-old antenatal woman, 10 weeks gestation, asymptomatic, had a routine thyroid check, and the total T4 is 15 micrograms per deciliter, the total T3 is 262 nanogram per DL, and the TSH is 2.3 international units per liter. So this is what happens in pregnancy. So in pregnancy, there is an increased demand for thyroid hormone, and this leads to altered physiology. So there is an increase in the TBG, and there is a decline in the TSH. So the total T4 and T3 increase because of the increased demand and the TBG effect, and the TSH declines because of the HCG effect. So this is actually a normal pregnancy and the TFT. On the other hand, a similar case, an antenatal woman, 8 weeks gestation, T4 is 14, T3 is 200, and her TSH is 0.05. And her free T4 estimation is normal. So this is a free T4 normal and a TSH which is suppressed. The diagnosis is a subclinical hyperthyroidism. So this is a suppressed TSH. And today, as on today, there is no adverse pregnancy outcome of a suppressed TSH on, and that is the reason we do not treat these women. So these are just examples of normal cases in pregnancy. Now, what is a normal TSH in pregnancy? So the pregnancy is a situation where there is an increased demand for thyroid hormone, and then there is also effects of the HCG. So what is normal in a non-pregnant scenario is not normal in pregnancy. So this is a very nice slide depicting the serum TSH and the HCG changes which take place during pregnancy. On the x-axis, you see the weeks of gestation, and then the open squares, the open rectangles is the HCG, and the black circles is the TSH. So as early as 8 weeks of gestation, as the TSH increases, you see as in 8 weeks of pregnancy, the HCG increases, and this reaches a peak. The peak is maintained between 8 to 14 weeks, after which you find a decline in the HCG. So parallel to the rise in the HCG, you find a mirror image, that is, there is a decline in the TSH. So between 8 weeks to 14 weeks of gestation, you find that the TSH declines. But however, in the second trimester and the third trimester, you see that the TSH returns back to the normal pre-pregnant range. So this is what happens in pregnancy to the TSH, especially in the first trimester. So in in 2011-12, what happened was taking into consideration that pregnancy is a situation where TSH declines, and then so many observational studies which showed implications of thyroid dysfunction on pregnancy, the Endocrine Society changed the guidelines, and then they said the recommendation is in first trimester TSH has to be below 2.5. And this was a very magic number, and I must tell you that 2.5 ruled the world of thyroid dysfunction in pregnancy for almost a decade. Even today, obstetricians will not be happy with the TSH of 2.6 or 2.7 or even 2.9. So this was a scenario where we don't know if we have overtreated people. So then came a good study by Lee et al., who looked at the relationship between free T4 and TSH between 4 to 12 weeks of gestation. So on the x-axis, you have the TSH ranging from 0.8 to 4.8. You find that the free T4 is constant. So this says that a TSH of 4 in pregnancy doesn't mean that there is a decreased thyroid hormone production in everyone. So the free T4 remains constant even with the TSH ranging from 0.8 to 4.8. Then after this recommendation by the Endocrine Society worldwide, TSH reference ranges have been studied, especially in healthy pregnant women who are TPO antibody negative, women who had iron insufficiency across various BMIs. They looked at the TSH difference ranging from 2.5 to 97.5 percentile. And then they found that in majority of the studies, they found that the TSH was more than 3. So this said that this was one of the earlier evidence which said that 2.5 is probably doesn't apply to everyone. Now, what happened in India is a similar analysis came from India. This was the first study came from Professor Marwa from New Delhi, who in 2008, he said in healthy pregnant women, antibody negative, the upper reference limit for TSH in the first trimester is as high as 5. Then data came from Nagpur and Rohtak with a lesser range of 4 and 3. And of course, one state was Manipur, which had a very low reference range of 1.8. So, it says that there is a variation of what is normal in different parts of even one country or different countries. So what is the trimester specific TSH range? What applies in the United States, you see, doesn't apply to China, and the same doesn't hold good for India and for other countries. So 2.5 may be normal for one particular ethnicity or a geographical location, and the same may not be true for others. So based on this, the American Thyroid Association in 2017 changed the guidelines of what is a normal TSH in pregnancy. It said that we need trimester-specific reference ranges for TSH. They have to be defined by assessment of the local population data. And then these reference ranges should include only healthy women with no known thyroid disease, optimal iodine intake, and a negative TPO antibody status. This is a very strong recommendation with a moderate quality evidence. It further said that if you do not have your own specific reference, TSH reference ranges, an upper reference limit of 4 may be used. And for most of the assays, this means a reduction in the non-pregnant TSH upper reference limit of only 0.5. So 4.5 is non-pregnant. So the reduction now is 4. So by and large, now our number has changed from 2.5 to 4. So this is about what is a normal TSH in pregnancy. Now I move on to hypothyroidism in pregnancy, which is classified as either a pre-existing or a primary maternal hypothyroidism. And maternal hypothyroidism in pregnancy is either overt or subclinical. The definition of overt hypothyroidism in pregnancy is any TSH of more than 2.5 associated with a low free T4 or any TSH of more than 10 itself. The subclinical hypothyroidism is defined as TSH between 2.5 to 10 with a normal free T4. So this is again a case showing about pre-existing hypothyroidism. So this is a 30-year-old woman, hypothyroid for the last 2 years, on levothyroxine replacement, planning pregnancy, and then she comes to you, and what is her target TSH you would advise her? So preconception management of hypothyroidism, monitor the free T4 and the TSH, adjust levothyroxine dose to between 0.5 to 2.5 milli international units per liter. So emphasize women with hypothyroidism planning pregnancy should be advised on maintaining a TSH of less than 2.5 to minimize adverse pregnancy outcomes. Emphasize on treatment adherence, and once pregnancy test is positive, pending the lab reports, an increase in the levothyroxine dose by 30 to 50% can be recommended. Well, monitor TSH every 4 weeks till 20 weeks of gestation, and after that, in the second half of pregnancy, at least once or twice around 28 and 34 weeks is what is recommended. So preconception, very important, is to maintain the TSH of 2.5 or less. So if there is, this is a case of a maternal hypothyroidism. So a 20-year-old woman was referred to you with 7 weeks pregnancy and the following TFT report. You can see her free T4 is low and her TSH is 12. So this is a diagnosis of overt hypothyroidism. Well, treating this woman is very important again to minimize, there is no ambiguity that you need to treat them very aggressively to minimize adverse outcomes. So how do you start treatment? You can start with a dose of, say, an empirical dose of 100 to 150 micrograms per day is recommended, or you can start with a dose depending on the body weight, 2 to 2.5 micrograms per kg per day. So this is a case of subclinical hypothyroidism diagnosed for the first time in pregnancy. So this is a 6 weeks pregnancy with a T3 and T4, which is normal, but then the TSH is 7. So that's at the upper reference limit is 4, so the TSH is 7. So this is subclinical hypothyroidism. Well, do we have any concerns in this particular case? So again, this is again a slide showing the relationship of subclinical hypothyroidism, thyroid autoimmunity, and a combination of subclinical and thyroid autoimmunity, the odds ratio for miscarriage. Well, any TSH between 2.5 to 5, you see the odds ratio is 1.62, and it increases to 3.4 once the TSH is more than 5. So it says that higher the TSH, more is the risk for miscarriage. And similarly, autoantibody, TPO antibody positivity again increases the odds ratio for miscarriage. You see the combination of subclinical hypothyroidism and thyroid autoimmunity. So as the TSH increases, there is a dramatic increase in the risk for miscarriage. So the TPO antibody status further augments the harm of a high TSH. So with this background, the American Thyroid Association again said that women who have anti-TPO antibody positivity, and if the TSH is more than 4, or even if the TPO antibody is negative, but the TSH is more than 10, you have to definitely treat them. The recommendation is a very strong recommendation. You may consider treatment if the woman is TPO antibody positive and if the TSH is between 2.5 to 4. Well, there's a good number of studies looked at TPO antibody positive women, and treating this marginal TSH, they did not find a very good benefit, and hence the recommendation is weak. You may consider treatment. And similarly, TPO antibody negative, and if the TSH is more than 4 but less than 10, again you may consider treatment. So this is about the management of subclinical hypothyroidism in pregnancy. Now, what about, this is the last case of a 29-year-old female who comes at 9 weeks of gestation. She is absolutely healthy. Her serum TSH is 3.4 milli-international units per liter. Well, is this a normal TSH value? A normative value for a TSH depends on so many parameters, depends upon the analytical method, depends upon the trimester, ethnicity, BMI. So all this can alter a normal TSH value. And that is the reason why we need population-specific TSH values. And then even, BMI-specific TSH values. Now, are you going to treat this woman? Yes, this woman with a TSH of 3.4 can be considered for treatment if she is TPO antibody positivity is present, or if there is infertility, or there is a history of a bad obstetric history. So does TPO antibody status matter? And if so, why? So again, as I already showed you, even in low-risk women, so this is again a study in low-risk women, 4 to 8 weeks gestation, with a primary endpoint of miscarriage, and in the presence of a TPO antibodies positivity, and then as the TSH increases, even in the normal range of TSH, and with an increasing TSH, you find that the miscarriage risks are high. Now, what about infertility? Infertility and TPO antibody status, again, found there was a similarly find higher miscarriage rates and lower live birth rates. Now, having said all this, when you treat these women, however, the benefit was not very evident till today. So the combination of TPO antibody positivity and subclinical hypothyroidism, levothyroxine is recommended with a combination of TPO antibody positivity and if the TSH is more than 4. It's a very strong recommendation. However, you can consider therapy with a combination of autoimmunity and a TSH more than 2.5 and less than 4 may be considered for treatment, maybe in certain situations like pregnancy loss or, So what about we move on to levothyroxine treatment in euthyroid and TPO antibody positive women. Well, there is no role in normal pregnancy, TPO antibody positive, and if the woman is euthyroid, there is no role for levothyroxine treatment. But however, there is a weak recommendation on prior pregnancy loss and women undergoing artificial reproductive techniques. Maybe a small dose may be would help in these situations. Again, the evidence is only very low quality. Now, a word about the TSH and thyroid autoimmunity in relation to pregnancy loss, both sporadic as well as recurrent pregnancy loss. If you look at hypothyroidism, the association is there, and when you treat these women with levothyroxine, the adverse outcome is minimized. What about subclinical and TPO antibody positivity? You find that the association is there. It is a strong association. But however, we do not have enough evidence to say that treating them with levothyroxine minimizes the adverse outcomes. So summarizing, you can see that the approach to a thyroid dysfunction in pregnancy should start with TSH. And if the TSH is, say, less than 2.5 percentile for the population, or if it is less than 0.1, it is probable thyrotoxicosis. You may have to evaluate further. But if the TSH is between 0.1 to 2.5 international units per liter, it is normal. There is no further workup needed. And similarly, any TSH more than 10, you have to treat with levothyroxine. The 2.5 to 10 TSH needs an antibody estimation. Antibody, TPO antibody, when we talk of antibodies, it is only the evidence is with the TPO antibodies. So measure the TPO antibodies. If the TPO antibodies are positive or negative, so if it is positive, again, you look at the TSH. If the TSH is between 2.5 to 4, you may consider treatment with levothyroxine. If the TSH is between 4 to 10, you have to treat them with levothyroxine. The evidence is strong. What about TPO antibody negative? If the TSH is between 2.5 to 4, no treatment is needed. And if the TSH is more than 10, you have to consider treatment with levothyroxine. So this is what is the latest recommendations of managing TSH targets in pregnancy. So the take-home message is that ideally, we need to generate more nationally representative trimester-specific TSH values. And as I've said, look at various factors which can influence the interpretation of TSH. It could be gestational age, it could be antibody status, it could be iron deficiency, pregnancy loss, multiple pregnancies, and then, of course, the analytical factors like the collection time and the immunoassay can all influence the TSH value. And a therapeutic threshold in subclinical hypothyroidism is based on antibody status. Well, till now, I was talking about 2.5 is the upper limit of normal, and then it has come to 4 after the 2017 recommendations. In India, a group of endocrine experts looked at this 2.5 and 4. So they felt that 4 was too high, and then 2.5 was too low. See, when you lower the cutoff to 2.5, more and more women are given a diagnosis of thyroid dysfunction and then unnecessarily treated without any added benefit. So the Indian experts felt that the upper reference limit for TSH should be around 4 it should be around 3 in the first trimester, and it is 3.5 in the second and third trimesters. So all antenatal women with positive antibodies, they should be treated if the TSH is more than 3, and antenatal women with negative antibodies should be treated if the TSH is 5. So this is maybe a very I think I've confused you with earlier. So I think the take-home message should be more simple. So maybe 3 and 5 looks very sensible. So, so TSH targets in pregnancy need to integrate many variables as we have discussed. And remember that one size doesn't fit all for TSH target in pregnancy. Well, I thank the Endocrine Society, both national and Andhra Pradesh, for inviting me to talk, and I appreciate the efforts of Dr. Ram Mohan Vamsi for making this event a function.